This is the another text for metabolic acidosis. B section. Carbicarb, available in Canada, is an equimolar solution of sodium bicarbonate and sodium carbonate. One of its advantages over sodium bicarbonate alone is that it doesn't undergo significant breakdown into carbon dioxide and water. However, it still runs the risk of producing hypernatremia and fluid overload. It may raise the intracellular pH more consistently than natrium bicarbonate. The recommended dose is 0.2 kilogram base deficit equal milliequivalent sodium. Trometamine 0.3 m is most beneficial in the patient with hypernatremia or a mixed metabolic respiratory acidosis because it limits carbon dioxide generation and will not raise the serum sodium. In contrast to natrium bicarbonate, it doesn't lower serum potassium, but it can produce hypoglycemia and respiratory depression. It is usually given as a continuous infusion and is contraindicated in renal failure. Kilogram base deficit milliliter of 0.3 m tom. In a mechanically ventilated patient, it's not unreasonable to hyperventilate the patient to lower the partial carbon dioxide. This will increase the intracellular and extracellular pH. Another section is metabolic alkalosis. A. Etiology. Excessive diuresis, especially from the loop diuretics, which promotes hypovolemia and depletion of hydrogen ions and chloride. Nasogastric drainage and inadequate chloride replacement by IV solutions. Total parenteral nutrition with inappropriate solid composition. Secondary as composition for respiratory acidosis. Pathophysiology. Hypovolemia stimulates aldosterone secretion, which causes sodium retention, which then prevents excretion of sodium bicarbonate. Aldosterone also increases hydrogen secretion into the tubules, increasing bicarbonate reabsorption. Second, decreased available chloride delivered to the distal tubules results in less chloride bicarbonate exchange and thus less bicarbonate excretion. Potassium loss directly increases bicarbonate reabsorption. This shifts hydrogen into the cells in exchange for potassium, raising the plasma bicarbonate concentration, and the lower intracellular pH stimulates hydrogen secretion and bicarbonate reabsorption. Adverse effects. Lowers the serum potassium level, potentially leading to atrial and ventricular arrhythmias, especially digoxin-induced arrhythmias, and to neuromuscular weakness. Has an adverse effect on the cardiovascular response to catecholamines that is comparable to that of acidosis. Shifts the oxygen hemoglobin dissociation curve to the left, impairing oxygen delivery to the tissues. This effect is offset in chronic metabolic alkalosis by an increase in 2,3 DPG in red cells. 4. Produces arteriolar constriction, which can compromise cerebral and coronary perfusion. Neurologic abnormalities including headache, seizures, tetany, and lethargy may occur, probably because of the associated hypocalcemia induced by alkalosis. These effects are usually seen with a pH 7.16. Decreases the central respiratory drive, leading to hypoventilation, carbon dioxide retention, and potentially hypoxemia. Treatment. Metabolic alkalosis is sustained by volume depletion, contraction alkalosis, as well as by potassium and chloride depletion. Thus, therapy should be directed towards correction of these factors. Potential contributors to alkalosis should be assessed. Reduce doses of loop diuretics or thiazides to avoid volume depletion. Use proton pump inhibitors to minimize loss of gastric and acid through a nasogastric tube. Avoid lactated Ringer solution and acetate that are metabolized to bicarbonate. The administration of chloride, usually as potassium chloride or sodium chloride, is the primary treatment for metabolic alkalosis. The appropriate solution depends on the patient's volume status and potassium level. In hypovolemic patients, 0.9% sodium chloride is the primary replacement fluid, and potassium chloride may also be given for hypokalemia. Volume depletion removes the stimulus for sodium resorption, allowing for more bicarbonate excretion. Chloride repletion increases chloride delivery to the distal tubules and augments the chloride bicarbonate exchange mechanism. Potassium moves into cells in exchange for hydrogen ions, which buffer the bicarbonate. The reduction in intracellular pH in renal tubular cells reduces hydrogen secretion and bicarbonate reabsorption. In patients with total body water overload, typical in the postoperative state, or with congestive heart failure, infusion of sodium chloride may exacerbate the edema. A potassium chloride infusion is beneficial if the serum potassium is not elevated, but it can only be given at a limited rate, 20 milliequivalent liter. During a profound diuresis with significant potassium loss, a faster infusion rate can be used. Alternative means of treating alkalosis in these states including the following: acetazolamide, diamox, 500 mg IV can be given in conjunctive with a loop diuretic to increase urine output. Acetazolamide is a carbonic and anhydrase inhibitor that inhibits proximal bicarbonate reabsorption by the kidneys, but it is a weak diuretic when used alone. It can lead to potassium depletion, so normal kalemia should be present before it started. One can also consider using a potassium-sparing diuretic such as spironolactone 25 mg per dose, amiloride 5 mg per dose, eplerenone 50 mg per dose, and aldosterone antagonist. Hydrochloric acid 0.1 norm 100 milliequivalent may be administered through a central line at a rate of 10 to 20 milliequivalent hour. It is rarely required in cardiac surgical patients. The total dose can be calculated based on a bicarbonate space of 50% body weight from either of the two following methods: chloride deficit method, base excess method. If a profound alkalosis is present, these doses should be given over 12 hours with intermittent reevolution.